Thanks. I'll present to you, well, good morning, everyone, or good afternoon. I'll present to you an anthrax outbreak investigation that we did in Ntabeni South Ward of Kwekwe district in Zimbabwe. Anthrax is a bacterial infection caused by Bacillus anthracis, and it is a disease of herbivores primarily and caused by Bacillus anthracis. Humans get anthrax directly or indirectly from animals, and usually it takes three forms, which is the cutaneous, pulmonary, and enteric. Our focus today is the cutaneous one, which is transmitted through contact with infected tissues of the infected animal. In Zimbabwe, anthrax is one of the notifiable diseases according to the Public Health Act. We received at the Provincial Medical Director's Office a report of a human anthrax outbreak from a meeting that was held at the Governor's Office on the 9th of October 2016. And 14 human cases had been reported to Ntabeni Health Center by the 3rd of October. But risk factors for contracting anthrax in this community were not known, and the district's outbreak response had needed to be evaluated because we had seen a big delay in terms of reporting this and investigation of this outbreak. So we broadly set out to characterize the nature and extent of the cutaneous anthrax outbreak and specifically describe the outbreak by person, place, and time. We assessed also we set out to assess the knowledge of the community on anthrax and establish risk factors for contracting anthrax, and then evaluate the quality of outbreak control. We conducted an unmatched 1:2 case control study where any person in Ntabeni South where a case was defined as a person in Ntabeni South who developed itchiness of the affected area, followed by a painful lesion, which became papular, then vesiculated, and eventually developed into a depressed black eschar from the 1st of September 2016 to the 10th of November 2016. In terms of sampling, we didn't have a large number of cases, so all our cases that were line listed were eligible for the study. We obtained our controls from neighboring households who did not contract anthrax. We collected our data using interviewer-administered questionnaires from the study participants. We also used a checklist for epidemic preparedness and response, and we also did some review of records. Our data was analyzed in EpiInfo, and we sought verbal consent from study participant, and we guaranteed confidentiality of information obtained. We sought permissions from the provincial medical director and the district medical officer of the district. Our results and discussion. 32 cases were line listed during the outbreak. No fatalities were recorded in this outbreak, and this is consistent with findings that are in literature, where cutaneous anthrax has a very low fatality rate if there is the treatment of cases. So we also found that the most affected age group was those of 15 years and above, with 68.8% of the cases. And there was no difference in terms of the median age between our cases and our controls. There was also no difference in educational status between the cases and the controls. The lesions of anthrax, we sought to find the most affected parts, and we saw that 32% were the fingers, 38% was around the fingers, 27% for the head and the face, and about 23% for the legs. This is also similar to studies that were done by Takawira and Mabaira, who had similar findings in terms of where anthrax lesions were common in an anthrax outbreak. In terms of the distribution by place, of the 8 affected villages, Gwembeni and Sidakwa had most of the cases from the 32 that were line listed. In terms of the knowledge of anthrax among the study participants, there was no difference of knowledge of anthrax, its signs and symptoms among the cases and controls. And the cases and controls had similar reasons for why they were consuming meat from animals that were dying of anthrax. This is a graph showing the epicurve of anthrax as it occurred in the community. On the x-axis, we have the date of onset, and on the y-axis, we have the number of cases. Cases started occurring in the community on the 28th of August. The provincial office got notified of the outbreak on the 9th of October, and outbreak investigation began on the 23rd of October. In terms of factors associated with contracting anthrax, we can see from the table that cutting meat and cooking and skinning animals was significantly associated with contracting anthrax in this community. Having no cattle deaths in the household was a protective factor. We can say skinning and cutting were also found by other researchers as a risk factor for contracting anthrax. Sika, Chirundu, and Mwenye in their studies also found similar factors during their when they studied anthrax. Continuing the risk factors, we also found that being married and being of an older age was significantly less, was also associated with less risk of contracting anthrax, while being younger, 18 and less, was weakly associated with anthrax. This we can say elder people tend to delegate duties to the younger ones, so they tend to be less exposed. And I think for why those less than 18 in this study looked like they were less weak, the association was weak, is because maybe our sample size for those who contracted anthrax in this population was small. Our other objective was to look at the outbreak response and preparedness. So the checklist has a target, and then we measured it against the achievement, and we made a comment of whether they were able, the district was prepared in terms of epidemic preparedness. From the onset of the first case in the community to reaching the first case reaching the health facility, there was only 1 day delay. But in terms of the outbreak case being seen at the health facility, and then the health facility reporting to the district health management team, there was a 39 days delay, which means there was a problem there. In terms of line listing, this was achieved. The health facility managed to line list the cases of anthrax that were occurring. There was a delay in notification of the cases to the field investigation, which was delayed by almost 3 weeks. The notification to concrete response, doing something to control the outbreak, also was 3 weeks delayed. It is also expected after the end of an outbreak to produce a report, and this was done in 2 weeks of completing the outbreak control activities. The delay in notification, there was delay in notification, investigation, and responding to the outbreak. This could mean the surveillance system in this at this facility or in the district itself was not sensitive enough to be able to transmit outbreak information on time. And there was a challenge also in that there was no telephone or radio communication at this site. A similar finding was also found in a study by Chirundu on anthrax in another community. Those are our references. In terms of conclusion and future steps, the anthrax outbreak resulted from contact with and consumption of infected carcasses, the meat, and its products. The community knowledge on anthrax was poor, and the quality of outbreak response was also very poor. Skinning and cutting were risk factors for contracting anthrax, and belonging to a household that had no cattle death was a protective factor. As a means of way forward, we said the DHE, the district health executive, in liaison with the health promotion unit, should organize awareness campaigns on anthrax to improve the community's knowledge levels on anthrax. The district health executive should also prioritize emergencies and ensure that resources are made available to attend to them. There was a significant delay in terms of the district acting to control the outbreak. The district health executive should also consider motorizing an environmental health technician who is covering 2 health facilities and to make her more efficient and effective, considering that she has a large catchment area to cover. And the DHE should also prioritize Ntabeni Clinic for the provision of radio communication so that they can improve dissemination of information.